Our show off is not what we have. Our show off is who we are. If I'm showing things what I have, that reminds me only single thing, that I'm not sufficient. Hello guys, this is Vikrant Sengar, pursuing MBBS from GRMC Gwalior. Now presenting a beautiful lecture on the great topic, that is the appendicitis part 1. So let's get started. So guys, I have posted my notes on my Instagram account, that is the Integrated MEDICOZ. Do follow it and subscribe to my channel. So guys, today's topic of concern is the appendicitis, and we will cover the whole topic into two parts, part 1 and the part 2. And the part 1 will have the preclinical portion, that is the anatomy of appendix, followed by the disease portion, that is the acute appendicitis. And the second part will have the diagnosis, right? And we'll be having the mandatory score, CECT USG findings, and the histopathology, and the management and treatment part will have the appendectomy and the Ochsner-Sherin regime, right? And today's topic of concern is the preclinical portion, that is the anatomy, and followed by the etiopathogenesis and the clinical features and the complications of acute appendicitis. Okay, so we're just covering anatomy, microbiology, patho, and the medicine in this part 1, and the pathology, medicine, radio, and surgery in part 2. Okay, so we'll start it. So first thing is the anatomy portion, right? And first we see the dimensions of that. That is the cecum and that is the appendix. Okay, and the size is the 2 to 20 centimeter on an average, that is the 9 centimeters, right? And that is the girth and the diameter, which is the 5 mm. Okay, so what is the intraluminal capacity of appendix, which is the 0.1 ml, right? And that is 0.1 ml, followed by the positions of that. Okay, so we will be having the retrocecal position, the subcecal position, the pelvic position, pre-ileal position, and the post-ileal position. Okay, and apart from those 5 positions, we will be having the paracecal position and the promontoric position as well. Okay, so we will go for these positions. So first one is the retrocecal, and we will be having the 11 o'clock orientation of appendix here, and in the subcecal 6 o'clock, and the pelvic position we are just having the 5 o'clock position, and the pre-ileal and the post-ileal, and both the positions are just directing towards 1 or 2 o'clock. Okay, and what is the most commonest position? The retrocecal one. What is the rarest position? That is the post-ileal one. Okay, and what is the most dangerous position? That is pelvic. Since it is directing towards the pelvis, that's why the abdominal signs of detection of this appendicitis is not being marked properly. That's why the diagnosis is delayed, more risk of getting perforation. That's why it is the most dangerous position. Okay, that's what the position is. So we will discuss the appendicular orifice. Okay, that is present 2 centimeter below the ileocecal orifice. That is the ileocecal orifice, and this is the appendicular orifice, which is present 2 centimeters below to this ileocecal junction or orifice. Okay, and the appendix is present posterior medial to the cecum. The posterior medial to the cecum, that is cecum, that is appendix. Okay, and that is the mesentery. Okay, and that is the peritoneal fold covering the cecum. Okay, and that is the meso appendix, the peritoneal fold covering the appendix. Okay, and these are the tinea. Okay, these are converging, these 3 tinea are just converging at the base. Okay, so what are the parts of the appendix? That is the cecum. Okay, and that is the appendix. We're just having 3 parts of that. This part is the base. Okay, and that this part is the body or corpus, and this part is a tip. So we're just having 3 parts of appendix. Done. So we're just having a valve that is called as the valve of Gerlach, that is present at this orifice to guard. Okay, so that is the superior mesenteric artery, and that is giving a branch. Okay, that is giving a branch, which is the ileocolic artery. Ileocolic artery. Okay, ileocolic artery here. So that is the ileocolic artery. Okay, and this artery is just giving 3 branches, 1 2 3. One branch is just supplying the cecum anteriorly, called as the anterior cecal artery, Another branch is the posterior cecal artery, and third branch is the appendicular artery itself. Okay, and appendicular artery is the end artery. Okay, and that is supplying the appendix. Okay, supplying the appendix here. Okay, and the branch of posterior, that is what, the posterior cecal artery. Okay, and a branch coming from this posterior cecal artery also supplies the appendix, and this branch is called as artery of Sacellum. Okay, that is called as artery of Sacellum. Done. Coming on to the histology portion of that, right? So we are just having the four layers as such here. Number one is, that is the mucosa, that is submucosa, that is the muscularis externa or muscularis propria, followed by the serosa, that is serosa. So what is the serosa? Serosa is a single layer of mesothelial cells, and that is actually a mesoappendix, right? In this case, that is serosa. So another layer is the muscularis propria or muscularis externa. Okay, that is circular muscle layer, and that is longitudinal muscle layer. Okay, followed by the submucosa, having the blood vessels, and apart from that, that is also having the lymphoid follicles right there. Okay, and lymphoid follicles are present in between the mucosa and submucosa, which are actually infiltrating or crossing the muscularis mucosae here. That is muscularis mucosae, and that is crossing the muscularis mucosae. So that is the epithelial cell layer, which is a columnar one, followed by its basement membrane, and followed by the lamina propria, and that is the muscularis mucosae. Okay, so that is the histology, followed by the disease itself. So now the etiology of this disease is like obstructive and non-obstructive. The obstructive is, that is the appendix, and that is the cecum here. Okay, something is getting lodged here, okay, causing the obstruction. It can be the feculith, okay, it can be ascaris eggs, it can be the appendicular tumor, it can be the fruit seeds or any foreign body. Okay, and that is obstructing here, followed by the non-obstructive cause and etiology, that is basically caused by the bacterial infection and more common in the children, and the organisms involved in this case are E. coli and the bacteria flagellis. Okay, and these organisms are just causing the injury, leading to the inflammation, and that inflammation, and that will be leading to the mucosal congestion, and that is causing the obstruction here. Okay, that is called as the catarrh. So coming on to the next thing, that is the pathogenesis of that. Okay, so first thing is the obstruction here. So that is the obstruction, that is cecum. Okay, and that is obstruction here. Okay, and obstruction will build up the pressure. So pressure, intraluminal pressure is increasing here, and with this the lymphatic, that is the lymphatic vessels which are getting obstructed here. Okay, so lymphatic obstruction is there, followed by the venous drainage is hampered. Okay, and the venous drainage is hampered here as well, and that will be causing the obstruction of the artery itself, leading to decreased supply of artery, that will be causing ischemia and prolonged ischemia, and that will be causing injury, and that will be causing the inflammation, which is the appendicitis here. And if this inflammation, this injury is prolonged and the ischemia is prolonged, that will be leading to the necrosis, and the perforation is there, which is a complication of that part. Okay, so perforation is there, and perforation, and that will be causing the content, the exudative content leaking from the lumen into the peritoneum, leading to the peritonitis right there. Done. So we will discuss the clinical features of that, and the clinical features are best depicted by the scoring system. We are just having a score, that is the Mentrel's score or the modified Alvarado score. Okay, so what is Mentrel? M stands for migratory pain, A stands for anorexia, N nausea and vomiting, T tenderness, R rebound tenderness, and E stands for the elevation or elevated temperature, and L is the leukocytosis, and S is shift to left. So what is migratory pain? Initially, the appendicitis is just causing the periumbilical pain, since the appendix is developed from midgut, and the dermatome for midgut is the periumbilical region. Initially, the pain occurs at the periumbilical region, and subsequently within few hours, 4 to 6 hours, the inflammatory fluid is being collected around the peritoneum, causing the irritation of parietal peritoneum, and that will be leading to the pain occurring at the right iliac fossa. So the migration of pain is there from the periumbilical region to the right iliac fossa. More precisely, that is the McBurney's point. Okay, so that is the migrated pain. Anorexia, nausea and vomiting, tenderness. If you're just pressing at the right iliac fossa, patient complains pain. Rebound, tenderness. If you're just pressing at the right iliac fossa, that causes pain, which is tenderness. But if we suddenly withdraw our hand from the right iliac fossa, that also causes pain, and that is the rebound, tenderness, followed by the elevated temperature and the leukocytosis and shift to left. And shift to left is the, that is the inflammatory condition. That's why the mature WBCs are also poured into circulation, and that is also called as shift to left. Okay, so each and every point is just giving the score of 1 except the 2. Okay, that is the tenderness and the leukocytosis, which are given the score of 2. Okay, so maximum score possible is 10 here, and out of 10, if the score is 9 to 10, the diagnosis is highly likely with respect to appendicitis. If it is 7 to 8, diagnosis is likely with respect to appendicitis. Okay, if the score is 5 to 6, okay, so the result is equivocal. It can be the appendicitis or may not be there. Okay, that's why for the confirmatory finding we will go for CECT in adults and USG in children. Okay, if the score is less than 5 or 1 to 4, that means diagnosis is unlikely. It will not be the appendicitis. Okay, so that is what the Alvarado score and the modified Alvarado score is, right? Coming on to the symptoms, as we have discussed earlier, these guys are the nausea, vomiting, anorexia, fever, which is a late presentation, of course, followed by the clinical signs. Okay, it may be Roswing sign, that is pressing on the left iliac fossa, patient complains the pain on the right iliac fossa. That is a Roswing sign. So what is psoas sign? The hyperextension of right leg with respect to hip joint causing the pain. That is a psoas sign. That is because of the retrocecal appendicitis. Since, due to the hyperextension with respect to hip joint causing the compression of appendix, retrocecal appendix with the psoas muscle causing the pain. Obturator sign, internal rotation of right thigh with respect to hip joint causing the pain because the obturator muscle, okay, that compresses the pelvic position of appendix, which is getting inflamed here. That's why that is causing the pain here. Okay, so that is the obturator sign. Dunphy's sign, okay, and the pain on cuffing at the right iliac fossa. So what is ten horn sign? The gentle traction of the right testis that will be causing the pain at the right iliac fossa. What is the Aron sign? That is, if you're just pressing on the right iliac fossa, that will be causing pain over the epigastrium. So that is the Aron sign. Okay, so these are the signs, followed by the signs based on the location of appendix. So first one is the retrocecal appendicitis. As we have discussed, that is present behind the cecum, and if we are just going for the hyperextension of the hip joint, right hip joint, causing the pain at the right iliac fossa because of the compression of the retrocecal appendix, which is inflamed by psoas muscle, that is causing the pain here. So post-ileal appendicitis. Since the post-ileal position is present deep to the abdominal surface, that's why the abdominal signs are not being elicited properly, and that's why we need to press very hardly, okay, so as to cause pain over the right iliac fossa. That's why we need to press very much forcefully and deeply to cause pain at the right iliac fossa. Done. Last one is the pelvic appendicitis. Since that is the abdomen and that is the cecum, the appendix is present at the pelvic position, that is the ilium, that is the ascending colon. If we are just causing the internal rotation with respect to the right hip joint, that will be causing compression of this pelvic appendix by the obturator muscle, that is the obturator muscle causing the compression of that, and that will be causing pain. And this pelvic position is present near to the rectum and the bladder. Okay, so that is causing irritation to the bladder and irritation to rectum. So that is causing the increase in frequency of micturition and the microscopic hematuria. Okay, and in this, due to irritation of rectum, that is causing tenesmus and the diarrhea. So in this case, obturator sign is positive and digital rectal examination is causing pain. Okay, in this scenario. So we will discuss the complications of acute appendicitis. First one is the perforation. If the greater omentum is not covering the acute appendicitis, that undergoes the perforation. Okay, so that is causing the perforation, and apart from that, the prolonged ischemia is also causing the perforation due to necrosis, followed by the gangrene, right? So if the prolonged ischemia is there because of the appendicular artery obstruction, that will be causing ischemia, necrosis, and the gangrene, followed by the abscess. If the E. coli or Bacteroid fragilis are just growing at the appendix, and that will be causing the the pus formation, and which is collected in the form of an abscess, which should be drained. Okay, so next one is the peritonitis. Okay, if in the case of the perforation of appendix, the content, the exudative content present within the appendix is being leaked out from the appendix to the peritoneum, is causing irritation of peritoneum and the inflammation of peritoneum, and that will be leading to the peritonitis here. Okay, that is done here. So we will discuss the last complication, that is the pseudomyxoma peritoni, which is caused by a carcinoma of appendix, that is the mucinous adenocarcinoma of appendix. Okay, if the metastasis of this carcinoma is taking place from the appendix to the peritoneum, and that will be causing the production of mucus and the jelly-like substance, and that is trapped in the peritoneum, and that is causing the symptoms, and that is causing the pseudomyxoma peritoni. And the symptoms include, since a jelly-like substance is growing and keep on increasing its mass within the peritoneum, so that is causing the obstruction of the bowel. Okay, and that is the first presentation. So next presentation is the increasing mass in the abdomen. First presentation is the bowel obstruction, second one is the a growing mass present in the abdomen, right? So this is over with respect to the first part of acute appendicitis. We will discuss the diagnosis and the management in the next part. So thank you for watching. If you're just having any doubt and query, you can go for the comment section below. Hit the like button for the sake of the motivation, and don't forget to subscribe. Pressing the icon will give me some vibe. So guys, we will meet at another section, that is the appendicitis part 2. Till then, keep it innovating. Thank you.